So, thank you for coming, everyone. And without further ado, uh, Ben, please feel free to take it away.
Hi everyone, my name is Ben Haseen and I'm going to share my screen real quick and just make sure that the audio settings are shown because I'm going to be sharing a video later on is on. Okay, so my name is Ben Haseen. Today we're going to be discussing the ethical care for queer and trans patients. Pronouns are he, him, his. First off, a little bit about me. I'm a third-year medical student at Morehouse School of Medicine. I'm openly trans and I'm South Asian American, Bangladeshi more specifically. I'm the first in my family to go to college and the first to attend medical school. And on the side, when I do have time, I'm a medical advocate, I'm a YouTuber, I have a YouTube channel dedicated to transgender patient autonomy and how to fight for their rights in the medical field. And I also do a little bit of public speaking. So I want to start off with some terminology, just so people are aware. There's a difference between sex and gender. Sex is often the assignment of male, female, or intersex based on birth identification. And I want to emphasize that usually when a physician assigns someone's sex, they do it by looking at phenotypic features. Not always do we do a karyotype test to see if someone's XX or XY. And gender identity is the innate feeling of a person with regards to being male, female, both, or something else. There's other identities such as agender, two-spirit. Other cultures have different terms for gender as well. And it depends on a social construct and personal truths within the person. A little TLDR of the LGBTQ plus alphabet soup. The L stands for lesbian, which is a self-identified woman who is romantically or sexually attracted to another self-identified woman. Gay is the opposite for men. Bisexual individuals is the person who is romantically or sexually attracted to someone regardless of their gender identity. Transgender people are those who are assigned a certain sex at birth, but do not align themselves with the gender expectations that they do have based on the cultural norms of that assigned sex. There's also two-spirit identities, which belong to the First Nation people, which is a blend of male and female spirits. There's people that are queer, which is an umbrella term for a social, political, intellectual movement to be radical with our own LGBT identities and fighting for our rights. There's questioning individuals who are questioning one's gender, sexual identity. It's an umbrella term for those who are trying to figure themselves out. There's intersex people who are either born with ambiguous genitalia or sexual anatomy that differs from the typical binary terms for sex. There's asexual people who do not have sexual attraction, and there's actually quite a few other terms within the asexual spectrum. There's gray aces that may or may not feel sexual attraction depending on their current situation. And of course, the plus stands for everyone else that's not being included in this alphabet soup right now, but definitely have a place at the table when it comes to justice and fighting for the rights of LGBTQ people. Now, before we get started, I want to show you the lack of representation of Asian populations when it comes to demographic studies when it comes to Asian LGBTQ people. And there are two major studies that were done to kind of see the population of queer people. And I want to show you how Asian people are not even included in these studies. One study from 2013 was the LGBT survey respondents of the US population that tried to see the percentage of queer identified people and put them in demographics, did not even include Asian people in their race and ethnicity section. They just grouped everyone else in the other category. And the biggest study that was done that tried to estimate the amount of transgender people in the United States was a 2013 study by the Williams Institute at UCLA. And even here, you see that Asian people are not being represented in demographic research. Asian transgender people are not being represented either. And that's a huge problem for me because when I do research, I want to see what kind of intersections exist between being trans and being Asian. And it plays a huge part on how we're treated in American society, how the healthcare system treats us. So just to give you a glimpse of how Asian queer people have those intersections, there was one study that was done, and it was in 2005 by the National Gay and Lesbian Task Force Policy Institute. This was the only study that looked at important issues facing queer Asian Pacific Americans. And we see that there are intersectional problems and issues that Asian queer people face. Number one being at the time, reminder that this is 2005, is probably very much different right now. Immigration was the biggest issue that Asian queer people were worried about. Then comes violence and harassment, media representation, HIV, domestic partnership, and at the top 10 we see healthcare as being a big issue. So right now I want to have a discussion because I do like talking to people and I like listening to what your opinions are. And I have a couple of cases and we're going to go through them, and I would love for you to pitch in on some of the solutions that we're going to face in these cases. So the first case we have is Shaba, who is a 27-year-old woman who presents to your clinic for a routine medical exam. She's a recent immigrant to the United States and has limited English proficiency. She's able to communicate that she is transgender and is pursuing hormone replacement therapy, but the physician does not speak her native language, Hindi, but is the only provider in her city that offers gender-affirming care. How can the physician provide Shaba with the care that she needs given the language barrier? And if you are a medical student, this is a really good like step one question. I'm sorry, Donna. So actually, recent changes in the Affordable Care Act enacted that that anyone who has limited English proficiency must be provided an interpreter. This is by law. So if a trans person who doesn't speak English very well goes to a clinic, which unfortunately the majority of gender affirming clinics are predominantly English speaking. I've never heard of one that does not, that has multiple languages that's serviced. She is entitled to a medical interpreter. It's by law, the physician will have to find someone to interpret for her. So there's some follow-up questions that I have. What if Shaba brings her partner who speaks English to this clinic? Do you think that there still should be a medical interpreter in this situation?
I think technically and legally, like, yes, absolutely, the services must be available and provided. I think in terms of like ethically and in practice, like what happens a lot, I'm sure for patients with limited English, you end up having like family members interpret when it might not be appropriate, when there may be discussions that may be hard to involve a family member in, or when you aren't sure about the family member's ability to really translate the way or interpret the way that you want to express what you want to express. But I think at the same time, there are times when patients are more comfortable with like with a loved one interpreting rather than using a phone service or an in-person interpreter.
Yeah, that's a great response, Kevin. The standards that we do have is that even if someone has a partner that speaks the language, is to still get an interpreter in the room. One reason is, like you've said, some parts of your stuff you don't even share with your partner, and you want that confidentiality when you are speaking to your patient. And also, even if this person's partner speaks English proficiently, they might not have a grasp of English medical terminology. And that's why professional medical interpreters are incredibly important, because they're able to convey that to their language that is spoken. The next follow-up question I have is, what if there are no physical interpreters available? What can you do then? Okay, Dandelion says that Zoom is a thing, and yes, telemedicine, telemedical interpreting is a thing, and also phone service is available. So if you are in an area where there's limited physical interpreters available, you can always use a teleservice to do the medical interpretation. The next question I have, what is the best way to speak to a patient when there is an interpreter in the room? This is also a step 1 question.
I would make sure the patient knows that I'm speaking to the interpreter first, and then I can speak directly to the interpreter, and then the patient would know that. Like, I don't have to be facing the patient. I can speak to the interpreter and have her tell that at the start. That makes sense.
So actually, the current medical standards is that you act like the medical interpreter isn't even in the room. You look at the patient, you address the patient, you talk to the patient, and if the interpreter is translating for the patient, you still look at the patient and pretend that you are hearing that from the patient. It just, it makes the flow of the conversation better, but also brings power back to the patient. The medical interpreter is just someone that's helping you with the communication, but they shouldn't be prioritized in the conversation.
Yeah, makes sense. Thanks.
I had a question.
Yes.
So this is just because I'm super curious, and anyone can definitely chime in, but you're the expert, so I figured you might know. So since COVID has hit, and like some people said, there's more video and Zoom calling, I wonder since physical interpreters may be obviously like limited, there's not as many in many places, and so if like Zoom or video interpreters have like kind of had a boom, or if it's like shifted the way how we do interpretation for patients.
I actually don't know specifically if there's been a boom, but that would be something really interesting to look into. I definitely think it's becoming more popular. And as people know more about medical interpretation, I've seen clinics not even tell the patient that they have the right to ask for an interpreter and kind of like dodge that question so they can get away with it, which is absolutely unethical. But I think it's important for every patient to know. And it's part of our jobs as future physicians and future like even community members to make sure that your community member knows, hey, you can ask for a medical interpreter and it is your right to have. So the next case I have is Yujin is a 22-year-old lesbian woman who presents to the clinic with dysuria and uncharacteristic vaginal discharge. After a thorough lab workup, you diagnose her with chlamydia. She begins to refuse care after giving the findings because her current health insurance is under her father's plan and expresses, I don't want my parents to find out that I'm sexually active with women. How can the physician calm Yujin's fears?
I would say expressing that the patient document, like the chart, is confidential, and that it wouldn't be shared with, anyone else on the insurance policy, for that matter. And then also, offering other solutions besides just, insurance specific solutions. So like GoodRx or, a bunch of other like affordable options in terms of prescription management for the patient. So that way there's like some shared decision making there.
Yeah, you really hit the nail on the head. Like, tell the patient that anything she tells you is protected by HIPAA, it's protected by law. The physician can't tell the patient's parents anything about her medical history, nor can anyone else involved in the patient's care. And also, yes, if she's absolutely worried about using her parents' insurance, then there are free clinics that you can provide the patient. GoodRx is a great way. I mean, I get my hormones for less than $30 a month, with GoodRx, and it's really just changed the way that we're able to buy meds for us.
I had a question just because in
Yes.
this scenario, this patient is 22, and I mean, I assume it holds true if the patient is like under 18, for example, but
Yes, even
uh,
if the patient is underage, if she can make autonomous decisions, it's going to be protected by HIPAA. So I have a follow-up to this case. 3 months later, Eugen comes in for a routine visit and expresses that she would like to come out to her parents, but doesn't want to lose her health insurance in the process of coming out because my parents are incredibly homophobic, but I don't want to keep living a lie and it's affecting my relationship with my girlfriend. What can the physician suggest given her frustration with her current situation?
I'm actually going back to the last question real fast. How would wouldn't the parents have the insurance claims for the treatment? And so how would we keep that away from the parents? Like they can see what the insurance claims are. Like the
Yeah, that's a very important question. But still within the claims, a lot of those claims are ambiguous and it's not given details about what was actually done. And a lot of ICD codes can be reorganized so that it doesn't give too much information. That's something that we do even with trans patients when they don't want all of their physicians to know that they're trans. We change the ICD codes to something more neutral so it doesn't give that away.
okay.
Does anyone want to tackle this follow-up? So actually Reshna, who just left, did an incredible answer this one. We can provide her with free medical resources where she can get her insurance if she comes out to her parents and her parents cancel her from her insurance plan. We should provide her resources where she can get her care for free. And also, I would suggest as someone in the community, as a physician, maybe to help ease her coming out process, maybe recommend a professional mediator to handle this conversation. And it's something that another clinic that I know have done with another trans patient who had to come out, and the professional mediation just relieved a lot of the anxiety that the patient had with the coming out process. So the next case I have is Hassan, who is a 32-year-old trans man who presents to Dr. Williams with the interest of undergoing masculinizing top surgery. Dr. Williams tells Hassan that he's unwilling to perform the surgery because his BMI is too high. Hassan has been under incredible distress the last 5 years because his dysphoria has been debilitating to his quality of life. Is the physician's decision to refuse gender confirmation surgery based on Hassan's weight ethical?
I guess I don't know what the sort of contraindications to surgery are. Um, I think in the moment, like off the cuff, it seems to me that there is a lot of situations where BMI is blamed for all kinds of health issues and related to all sorts of health issues that it isn't or shouldn't be. Um, but at the same time, like I think if this doctor is like acting on guidelines that are evidence based about like any sort of mortality risk um, that have to do with outcomes, that have to do with like patient health, I could understand why. But I think in terms of communicating that, I think that there are probably better ways to communicate it, and there are better ways to sort of like deliver this news, better ways to coordinate with, you know, people who are probably receiving care from other doctors who might be like, if this is the barrier, like if BMI is the barrier, then like have that be an ongoing discussion with the patient so that like this news isn't sort of delivered all of a sudden, and like leading to this sort of like sudden disappointment when it's such a cause of distress for the patient.
I think that's a really, really good response. I mean, you hit the nail on the head. And I went out of my way to do research on whether or not it's ethical to deny overweight, obese, and fat patients masculinizing top surgery. And I made a video about it after I did my research so that patients know if that is something that should stop them from getting top surgery. And I'll just play the video and explain it because like I had a whole script for this video. So this explains it very well.
How's it going, everyone? Ben here. Today we're going to be talking about whether or not being overweight or fat should keep you from getting top surgery. And I know this is a very high anxiety topic for people who are overweight and fat, who are trans and want to get top surgery, but I want to ease your burden by immediately saying the conclusion of this video is that it shouldn't prevent you from getting top surgery, and I'll be explaining why. The reason why I wanted to make this video is because I know a lot of people in the trans community that are often shamed for their body type because mass media loves to show trans people as skinny, tall, and if they're trans masc, very athletically built, and that's not necessarily the case for most trans people. Most trans people come in a variety of shapes and sizes, which are beautiful, and they don't need to stick to a certain standard the society deems them to be valid. Most of the information presented in this video is actually taken from Dr. Scott Mosser's YouTube page, where he talked about are there BMI or weight requirements for top surgery. I was inspired by that video, but as a trans person, I feel like I need to add a little bit more to his scientific explanation of having a higher weight and getting top surgery. And if you don't know who Dr. Scott Mosser is, he's one of the largest well-known top surgeons in the country, and he also does a number of transmasculine and transfeminine procedures as well in his practice. He's also one of the very few doctors out there that actually recognize non-binary patients and recognize that non-binary patients also have the unique needs when it comes to an aesthetic appearance after getting gender-affirming surgery. So yes, I do respect this doctor a lot, and I incredibly respected the way he presented this case of actually allowing fat and overweight people to undergo top surgery. Dr. Scott Mosser noted himself that he personally has no weight requirements for trans patients who want to get top surgery, and the fact that he has done multiple, even dozens of surgeries where people have a BMI higher than 35, and he himself acknowledges that BMI is not the best indicator of whether or not someone is suitable for undergoing extensive surgery. He also has noted that he himself has done quite a few top surgeries where the person's BMI was over 50. So why is it that there are some surgeons who are creating weight requirements for top surgery? And I'm going to come to the conclusion that most of these surgeons are afraid of litigation, and they're afraid of performing a surgery on a type of body that they're not very comfortable with. And that says more about the surgeon's expertise and the surgeon's comfort and the surgeon's own willingness to perform a surgery than the patient themselves who want to go through that surgery. There's actually no statistically evident paper out there that shows that top surgery and weight has a correlation with increased risk of complications. There has been none. So most surgeons who create these weight requirements are creating them from other types of cosmetic procedures that have shown to have statistically evident complications with those procedures with weight. However, I'm going to put a big asterisk because I have looked through some of these studies, and I have looked through newer studies, and newer studies are saying that weight should not be something that keeps people from getting the surgery that they want, especially if it's a surgery that would improve their quality of life. And it just doesn't have to do with improving the quality of life. Older studies kind of have a lot of confounding variables, and when you look at older studies and when you look at newer studies, the results, depending on the paper that's written, kind of goes against one another. Some say that it is statistically significant, some say that it isn't statistically significant, which is showing that we can't really come to a consensus whether or not weight plays a huge role in complications of surgery. There are so many other factors that can lead to complications. I will even argue that it's not weight that's causing the complications, but morbidities such as diabetes and hypertension that causes complications. And yes, I am going to say this, but people of all sizes have diabetes and hypertension. Actually, diabetes is one of the most common disabilities out in the world, and not everybody with diabetes is fat. That is a very, very inaccurate description of who someone with diabetes is. The same goes for high blood pressure. There are numerous types of minorities that have a higher predisposition to high blood pressure, and that does not correlate with someone's individual weight. A 2009 study concluded that post-operative complications were frequent in abdominoplasties, which is a tummy tuck, but overall complication rate did not correlate with body weight, body mass index, age, surgical technique, or surgeon's experience. Now, this is a study that was a little bit over a decade old that came to the conclusion that actually your body weight does not predispose you to complications, but the risk of complications is actually pretty high regardless of whatever type of cosmetic surgery you're getting, which is true because I am a tiny person and I still had complications after surgery. I had an infection in one of my sutures because the suture was embedded in my skin. I needed to come out and take a longer time, so it started to get infected. So I too had complications post-surgery. I also had complications when it came to eradicating my bowels. We talked about this before in that video that my partner was in at. It's a very interesting story, so go feel free to watch that after this. Another study looking at 179 patients who's undergone breast reduction in 2008 came to the conclusion that it is safe to perform large volume, which means a lot of tissue is being removed, breast reductions in the morbidly obese patient with comorbidities as in everyone else. Lastly, I want to highlight a more recent study conducted in 2019, less than a year ago, that concluded that tummy tucks with or without concurrent liposuction in obese patients is a safe and effective procedure with similar perioperative complication rates as the non-obese population, saying that yes, you will get complications. You might get complications after your surgery, but that does not necessarily correlate to your weight. Actually, your healing is more correlated towards your smoking usage than your weight. That's why a lot of surgeons recommend that you quit smoking for a while, at least for a while, if not forever, because it's better for you in all aspects of health, before you undergo a surgical technique, because smoking actually reduces your ability to heal properly. All of these studies will be linked down below that I cited, but there are many other studies on PubMed that you can look up that's showing the correlation between being fat and having complications with surgery. You will see that a lot of them have inconclusive evidence, or they have a very, very small patient population that can't allude to the larger body of people that are getting elective surgeries. Now, even though these studies use the word obese, I'm intentionally using the word fat because I think it is more inclusive towards all different types of populations, including minorities who are often misrepresented as a higher weight collectively that nobody really wants to talk about. So in conclusion, I want to tell you that if you go to a doctor asking for top surgery and they say that you weigh too much or that you need to lose weight for your surgery, they are talking more about themselves than they are talking about you, because that means they are trying to prevent themselves from getting into an uncomfortable situation where they're doing a procedure that they're not comfortable with, but they need to get comfortable with. It is then where you try and find a doctor that is more fat inclusive and is willing to do that surgery on you and explaining the risks and benefits of each of them by treating you with respect at the same time. I hope you.
So yeah, I did a lot of research on whether or not it is ethical, whether or not it's okay to do top surgery, masculinizing top surgery on higher weight patients, and the results is fine. It's like you can get it done. If a physician is telling you no, they can't do it, they're taking information from things that do not align with top surgeries. They're usually using another surgery. A lot of gallbladder surgeries, there is a correlation with weight and complications with gallbladder surgery, but you can't apply it to something that's a subcutaneous surgery. So the next case I have is L, is a 43-year-old non-binary person assigned male at birth who has been undergoing estrogen replacement therapy for 7 years via injections. Recently, L has been diagnosed with lupus, which is a common illness that happens with people of minorities, and is taking prednisone. which is leading to increased bruising when they inject estrogen. L is distraught at the clinic because they are afraid that they will be asked to stop hormone replacement therapy. What can the physician do? And I know this one's a hard question to answer. So like, I'm not gonna ding anyone for being wrong.
I think what comes to mind is that there's like multiple ways that you can deliver estrogen. So if injection is causing bruising, they can discuss other forms of estrogen, like whether it's oral estrogen. I think there's also like patches of estrogen that people can wear. And maybe that would be something that the person that L would be more amenable to. I'm also not sure about like the long-term treatment of lupus and whether prednisone is like the only thing that can be used, or if there's like another immunosuppressant that could be used that causes less of this bruising. So those would be the two sort of options that come to mind.
So that's exactly what I was going to say. There's multiple modalities to take estrogen. Initially, when someone starts hormone replacement therapy, they do injections because it allows you to hit your desired levels very quickly. But after that, after you get your first year of changes, you can start tapering to other methods. There's estrogen patches, like you've said. There's also an estrogen gel. People take oral spironolactone, which is a diuretic, but has shown to increase estrogen within someone's body. So sometimes Spiro is prescribed. And like you said, Kevin, there's also other treatments for lupus. You don't always have to be on prednisone. Sometimes you do when you're having a really bad flare, but the standard methods of care for lupus is actually things like hydroxychloroquine or other immunosuppressants. I think I see someone say something in the chat. I'm just gonna check it really quick. Oh, okay, yeah, Kevin's got it. And this is the last case that I'm going to cover today. And Sam is a 32-year-old bisexual man who makes his first appointment with you. You are going through his social history with him, where he expresses that he is polyamorous and has multiple consensual sexual partners. How should you adjust your sexual history questions so that you don't miss any important facts about his sexual health while still being respectful? This is actually something I'm trying to figure out on how to best approach. So your input can help me a lot.
Well, I guess something as simple as using inclusive language, right? So when you're asking about sexual history about the partners, like, you know, typically people would just default, right, to husband, wife, or whatever, but just to not assume. So I think that's like, obviously the terminology is really important. If there are more ways, I feel like you and other people might know more than I do.
So I think the way I would approach it, and I don't think I'm perfect at it yet, is first I would like to validate his polyamorous identity, and then ask him, like, who are his partners? You know, what are the gender of his partners? And then next I would go into more specific questions so that I can get a detailed sexual history. What kind of sex are you having? Are you having penis and vagina sex? Are you having oral sex? What kind of parts are you using when you're having sex? And I think just getting the patient comfortable to talk about those things and then leading it to those more specific questions is how I would approach it.
Yeah, I think I have encountered that where someone has asked sort of more broadly, right, rather than like, oh, like, I think like obviously avoiding terms like normal sex or like just sort of asking like, oh yeah, like what parts of your body do you use and how? Like I feel like is a sort of very broad way to ask about sexual history.
Exactly. And I really wanted to include this case because I know a lot of people who are poly And when they go to the doctor, the doctor assumes they have only one partner and keeps asking about that one partner. And there's almost no literature, I don't think, about like accurate sexual history taking for polyamorous patients. So I want to end this discussion with a couple of slides. I asked a bunch of my friends, some of the most like annoying things physicians or medical providers have asked them while they were at their appointments. And some of the things that my friends have said is that the physician did not acknowledge my transgender identity and ignored me during my visit, ignored the entire fact that I was transgender, and like didn't even want to address it, which is, I think, is a huge problem because being trans is a big part of your medical health and personal health. The next quote is, the doctor insisted that I have a pregnancy test despite me endorsing not having PIV sex ever in my life, which I see a lot with lesbian women who have to undergo any type of surgery. The physician still asks them to do a pregnancy test. Then the physician traumatized me by asking to take my binder off multiple times without realizing how personal this ask was. If you don't know what a binder is often it's often a piece of clothing that you put on top of your chest if you are someone assigned female at birth who want to have a flatter chest but not undergo surgery as of yet. And it flattens the chest so that you can pass as more masculine to society. However, some medical students who don't know what a binder is can be a little bit insensitive when they have a trans person at their clinic when they try to also take them and hear their heart sounds. A great way, does anybody know how you could like approach that if you are a medical student and you have a patient with a binder who's uncomfortable with you being around their chest?
I mean, I think the first thing that I would just ask myself is like, is it necessary for them to remove their binder? Because a lot of the time, like I can't even, I mean, I guess if like you're trying to like listen to their heart or something and the binder is like really in the way, but like even then, like a lot of times these like heart exams like are not that necessary. And it's very rare for me to actually need to do like a breast exam, for example, for someone. So just thinking about like whether like, am I just asking this because this is something I do all the time, or is this actually indicated? Would be my first thought.
Yeah, absolutely. And some stethoscopes are so advanced, you can like hear through the piece of clothing, and binders aren't that thick at all, really. Another thing that I learned is that in pediatrics, oftentimes we even ask the child to take the stethoscope and put it on their own chest so that the child is interested in the exam. So what you can do is ask the patient, hey, you can take the stethoscope and you can put it under your binder and put it in the position I ask you to. I can point to that location, they'll put it there, and then you can hear the chest. Sometimes these things have very simple solutions, but like just needs a little bit of thinking outside the box. And lastly, another quote my friend has told me is that one time I had to change providers and the new doctor told me the only reason why I needed testosterone was because I had gender dysphoria, not because I'm transgender, insinuating that I have a mental illness. So I want to go back. I want to share a personal story with y'all, and just to show you how important it is to be an advocate for trans patients. And in Atlanta, we had an artist named Ash Walsh. I'm from Atlanta. And a year ago, he was diagnosed with acute myelogenous leukemia at the age of 27. Unfortunately, his cancer went to stage 4 and he was transported to a medical center at Texas where he was going through clinical trials for his leukemia. And one day I got a call from him in last October. I got a call from him and he said, Ben, my doctor doesn't want to prescribe me testosterone anymore. He thinks I'm going to bleed and he thinks I'm going to die. And he's not willing to understand what that means for me. And I really need your help. At that time, I was studying for step 1. I was studying for my classes, and I was like, you know what, I will absolutely help you. So while I was studying for my finals, I was in conversation from Atlanta to physicians in Texas, trying to advocate for Ash, trying to get him what he needs. And his doctor didn't even know that there's testosterone patches that exist. His doctor's concern was that he was going to bleed from the injections. So we were able to get Ash his testosterone through patches. And the last words he said to me was, "Thank you so much." And he passed away a month later from leukemia. So I just want to tell you like how important it is for you as future physicians to advocate for trans patients. So that's the end of my lecture. Does anyone have any final thoughts, questions?
I have a question. I think one thing that's been really frustrating, as you mentioned at the beginning, is that right now there's just so much invisibility with regards to how Asian Americans and other Asian diasporas within the LGBTQIA community kind of experience, different challenges, different kind of health barriers, and kind of the medical community and public health community at large just don't really recognize us as a population of focus. And just thinking long term, like how can we better advocate for our presence and really shift or create a limelight that can be focused on those issues. And I think that's I think a lot of people are interested in fighting for that, but still, like, I feel like not much, the needle hasn't really been pushed that much farther than before. So if you have any thoughts or ideas on how to really advance this, that would be really interesting to hear about.
I agree with you. I have my own frustrations about Asian people kind of being put in the back burner, even though we make so much of America's history. I would just say, just like keep being loud, get into higher level positions where you can be like, hey, we need to talk about this. Like, I'm just very annoying about being Asian, and I don't care. Like, I'm Asian, get used to it. I want more Asian representation everywhere. I know sometimes that's not taken very well, but like, I'm as frustrated as you are. And this is definitely something that's gonna take years for us to change. And I hope that you fight for it and continue to fight for it.
Well, if there's no other questions, I know everyone's busy with their med school life. I think, Ben, you just took step 1 like a week ago, right?
I did. Oh my God, that was horrible.
Well, congratulations on that, and thank you so much for taking your time to come and speak with us. And hopefully, like if you ever have any other ideas about, things about transgender care that you want to talk with us about, things about API health that you want to talk to us about, like we would love to, have more events with you, and we'll definitely push for people to check out your YouTube. And yeah, best of luck with everything.
Thank you for having me. It's really important. I know I talk a lot to LGBTQ organizations in general, but I always love an opportunity to educate non-queer folks. I mean, that's how we get change happen. Our allies are very important when it comes to having our needs met, because they are so much bigger as a population than us. So thank you for having me.
Great. Well, thank you everyone else for attending tonight and being part of the discussion. And yeah, hopefully we'll get this up on our APAMSA YouTube as well.
Thank you.
Thank you so